If you go back to the days of Jocelyn and some of the other pioneers in diabetes from the early 1900s, early 20th century, I think even at that point, they were thinking that they were including that carbohydrates were a problem before the invention of insulin. I think Louis Newberg or somebody, I think, was talking about very low carb diets. And what was the decision that led to the recommendation of high carb diets for diabetics?
Good question. If you read the writings of Gary Taubes, are you familiar with Gary Taubes?
Yes.
He wrote a book called The Big Fat Lie, but prior to that, he first wrote a lengthy article that got published in the journal Science, where he gave the history of how these low-fat, high-carbohydrate diets came about, and actually documents the bribery of institutions and researchers by manufacturers of carbohydrate products. And they cited Nestle, they cited General Mills with cereals, and a few other big manufacturers for literally bribing investigators and institutions to draw conclusions from their research that were the opposite of what their research actually demonstrated. And Taubes' article in Science was apparently so convincing that the New York Times Magazine, which was a very important publication way back in those days in the, I guess it was the 1970s maybe, they had a section called the Rotor Group with great photos. And they published a multi-page article by Gary Taubes, which was, I believe, a copy of the article from Science. And I had that. It's probably still buried in my files. And he goes through the whole history of this. More recently, a couple of investigators backtracked and again published in the journal JAMA, Journal of the American Medical Association, a history of these payoffs that led to this popular misinformation.
I saw recently the American College of Physicians is now recommending that, I believe it's type 2 diabetics, it might be type 1s as well, maintain a hemoglobin A1C between 7 and 8%, which is extremely high. What is their justification? They're worried about hypoglycemia, I believe, but why are they doing this?
I've had patients who, remember, for many patients, to get their insurance to cover their supplies, they have to have a doctor associated with the insurance company. On the West Coast, there's the major, literally has its own hospitals, its own doctors, and they have to approve the supplies that the patient gets. And the patients ask the doctors, why are you demanding this? And there are two answers that they get. One answer is because that's the guidelines. Guidelines are guidelines and you have to follow them. The other answer is to prevent hypoglycemia. Now, it's interesting that there were several studies that documented the frequency of hypoglycemia versus hemoglobin A1C, which is a measure of the average blood sugar. And what these only a couple of studies, not many, and I can't even cite who did them and when they did them, it was a while back. They found that the people with the highest A1Cs had the most hypoglycemia. And it was probably because they were being given, my guess is that they were probably getting the most carbohydrate and being given the most insulin, which leads to the most unpredictability. So you can't really say that shooting for a high A1C or a high average blood sugar is going to minimize hypoglycemia.
Yeah, fair enough.
But that's what they're saying.
Yeah, others have pointed out, high levels of insulin often indicate or often associated with overcorrections, and they bottom out, and then they eat a bunch of carbohydrates because they feel hypoglycemic, and then they shoot up high, and it's a vicious roller coaster that they can't get off of.
Yeah, the roller coaster effect is very common in type 1 diabetics.
You,
And I treat a lot of type 2 diabetics. Usually by the time I see them, they're still not on insulin. They usually come to me with high blood sugars. They're maybe on some oral agents and on high carbohydrate diets. And by the way, the biggest thing you could do to improve their blood sugars is to cut the carbohydrate. Cut it down.
Yeah, that's pretty clear.
Way down.
Dr. Bernstein, you had mentioned, you said that you had a 15-year-old gal that was told to take 70 units, and you said that the normal pancreas is going to put out about 18 units. Is that, where's that information come from? And is it?
A very good question. I stumbled on this a long time ago when I was first in practice. There was very little information as to how much insulin does a non-diabetic adult make in the course of a day. And a doctor who eventually became a friend of mine named Philip Fehlig had edited a book that cited a study. I don't think he did the study, but it cited a study where they found that a typical non-diabetic made 25 to 35 units of insulin a day. I think it was a person weighing around 150 pounds. And that was the only information I've ever seen with regard to how much insulin a human makes in a day. And I used that as a guideline. Over the years, I did not use it as a guide that this is how much insulin I should give to my patients. What I gave them was what it took to normalize their blood sugars, combined with the diet that I felt would enable them to have steady blood sugars. I've been treating patients with oral agents, insulin. The major thing that they all get is the diet, which is low in carbohydrate.
Let me ask you, there was a study that came out several years back called the Accord trial, where they looked at intensive glucose management through drug routines, not diet. And they actually had to stop the trial early due to increased cardiovascular disease. So are drugs alone? Go ahead.
Wait, stop. The Accord trial was retracted. The original report was given a lot of publicity. The guy who was the senior author of the trial did not believe that diabetics should have normal blood sugars. And the trial was stopped early because supposedly it showed that those with more intense treatment died sooner. And the study was closed. The detailed data was not disclosed. I had run into two people who were investigators in the study who told me that they were from out of town. They were called into New York for a meeting and told, if you sign this declaration that states that the trial found that tight control was causing deaths, you'll get paid and the trial is over. And that was contrary to their findings. But they gave it a lot of publicity. They had money for press releases, and senior people were going around the country publicizing this result. About 5 years later, one of the junior investigators under the Freedom of Information Act got hold of the actual data because it was supported by the NIH, by the federal government, and actually looked at the real figures. And what they found, it was a couple of investigators, was that the people who were dying prematurely was those with the highest blood sugars. And that was not disclosed anywhere in the results of the trial. So the investigators, the original investigators, the senior ones, were forced to retract And in the same issue of diabetes care, which you can look up some 5 years or more after the initial trial, you'll see a retraction where they state that it wasn't the low blood sugars that killed people, it was the high blood sugars. But their retraction, giving their reasons for why they came to the wrong conclusion, is undecipherable, is gobbledygook. You can't understand what they're saying. And in that same issue of the journal Diabetes Care is the report by the whistleblowers showing the actual data and how they drew their proper conclusions. Yet to this date, because the retraction did not get press releases, the ADA did not publish press releases about this historic retraction, everyone is remembering the first report, not the second report. Just like you're remembering, because you probably never even saw the second report because it didn't get publicity. What do you make of that?